So with that, Dr. Barzilay,
Thank you very much. Thank you. Thank you very much for inviting me over. The title of my talk that I received, I think, from Wendy is Equity and Algorithm Development. So let me go with my talk. So this is my disclosures. And the point that I want to start with is to acknowledge there is a lot of uneasiness in general public, about AI and the fact that it may worsen health disparities. But we have to acknowledge the fact that the disparities were there all the time. AI didn't introduce them. And I just want to share you one numbers. I'm following on Dr. Levy's presentation from yesterday about TerraQusic, and you can clearly see that a TerraQusic model, which predicts the risk of breast cancer, is not doing great for any population. This is AUC, where 0.5 is random. You can see it does abysmally on Asian and African American women, while this model is today used clinically in many centers. So now with AI, we actually have a chance to rethink about it and to improve those problems. But we need to be aware that there are three reasons why we have to be super careful with deep learning models. First of all, they are data hungry. And when I mean data hungry, we talk about sometimes 50,000, 100,000 images that for many specialties we will not have them. And I'm talking about kind of out-of-the-box models. It's not the most sophisticated models. It's the models that you can download and run. The second problem that we have is the inability of these very standard models to deal with a distributional shift. As you can see here, the example in terms of numbers, that if you train the model on black and white numbers, it does perfect. Whenever you change the background, a trivial task for a human, the model really drops in performance. And the third point is that whatever bias that you have in your data, the model is going to pick it up. For instance, the top image recognition model would look at this monkey and predict that it is a human because in the training data, it always saw guitar near the human. So now what I'm talking about, we're talking about the basic model. And those of you who had my question yesterday, I asserted the majority of models that today are published, Nature Medicine, Science Translational Medicine, use a very basic model and not the most sophisticated one. So with the title of my talk, I want to show you what are the tools that one can use to deal with these issues. And case studies that I want to talk about in case of diagnostics, it relates to two applications that I would show you. But before I show you the applications that we developed, I want to say that the vast majority of diagnostic tasks that we really care about are not the ones that we can solve as humans. Because none of us can look at the image, none of you guys can look at the image and say, is this patient going to get cancer in 5 years? How bad is going to be the cancer if a recurrence happens and so on? So the problem with this task, and here we need to be very aware, that human cannot validate the prediction. If human cannot solve the task, who is going to be validating the model? And many of these models, you can validate their prediction many years later, not now. And here I'm showing you two applications that we developed and extensively published in oncology. One is called Mirai. Mirai predicts the risk of breast cancer within 5 years, up to 5 years, looking at non-malignant mammogram of a patient. And on the other side, you can see our newer model, which is called CBEL. It takes a low-dosage CT scan and predicts the likelihood of a patient to develop lung cancer within 6 years. And what I'm going to share with you is various algorithmic things. We had to introduce novel algorithmic things to ensure that these models are actually robust. And for those of you who are interested, the models are publicly available, published, validated. So how the model can learn to solve the task that human cannot solve, meaning predict the future risk of cancer, of course, you need to train it on a data where you have an image and you have outcomes of this patient for the next 5 or 6 years. And you can clearly see here that, there is significant boost with the models that are currently used clinically. Now, the question that we discussed yesterday when we were very unfortunately acknowledging the fact that sometimes weak models do not generalize, we actually made sure that our model generalized. In 2020, we validated model in multiple centers around the world. You can see 7 centers, some different populations. You can see below the AUC and C index is actually pretty high. Today we build a hospital network, and I know there are some people from MSK and others which are part of the network that we are validating the model in all these different parts. So I think this is really an essential component of it. So now let me start talking to you in the remaining 5 minutes about the algorithm. So the problems that we have today is, as many of you acknowledged yesterday, that whenever we are taking the model validated on one population and train on that population, we have no clue what happens in the different population. And it relates to demographic, clinical setting, device, and so on. So the good news that I want to tell to Mirai, even in our early work, because our data contain relatively diverse population, and we use some smart algorithmic tricks, we were able to demonstrate that Mirai actually works well across different populations. And the question is how you can force algorithmically the model to do that. So actually, because when you are training the algorithm, if you have a minority data set in your group, the algorithm tries to optimize for the majority, trumping the performance on the minority. So what we are doing here, we're actually forcing the algorithm to see the majority and minority kind of in the same way, learning the representation correctly so that it kind of eliminates unnecessary differences between them and focuses on improving accuracy across this population. And we demonstrated that it really helped. And this class of anti-bias algorithms are called invariant representation invariant algorithms. But the problems that we have now is that most of the time we actually don't know when the bias is in the population. So what I showed you, I knew what kind of bias to expect. For instance, I knew there are different machines and so on. Most of the time we don't know. And I can tell you during Q&A, really terrible cases. It even happened during our development that the model was learning wrong things and we didn't know until much later. So the good news is that in the last few years, we actually developed algorithms that enable you to automatically identify outliers and out distribution samples in your data. And then come to the question, when you even have a large data that come from multiple centers, how do you split it? Do you just do it based on the center, on the time, and so on? So right now we have, and I can demonstrate to you that depending how you split your data, you train and test, you can get very different numbers. If you do some random split, you get 78. If you do a very sophisticated split, really looking at outliers, your accuracy drops to 33. So in this particular case, we actually develop an algorithm that can take the data and identify outliers. In this case, the outlier will be Samoyed on snow and a bear on white, which was a confusing case for the algorithm. And another thing that I want to spend my last 3 minutes talking about the biggest misconception I've had yesterday. This discussion about transparent models and explainable AI. We absolutely can use explainable AI if we can do the task. But if we cannot do the task as human, how a machine can do it? And there is this beautiful paper written by my colleague at MIT, Barzilay at Lancet Digital Health, about that it really goes into the detail why it is so dangerous to believe that we can use this interpretable model to improve the adoption in clinical system. It's even more concerning that this kind of language appears in the FDA regulations. And the point is that if you as a pathologist or you as a radiologist cannot solve the task of predicting the future or predicting where the patient is going to get recurrence, how you can validate what machine is doing. And as an alternative, we actually start looking at the models which do what your machines do at home. Like if you're using microwave, how many of you really know how microwave works? I would bet no one. But you know that it works every day, and if there is something wrong, there will be a red light that is flashing and tells you it doesn't work. So that's exactly what we want to have our machines doing. That if it can take a patient and it can very reliably tell you that I can make prediction and my likelihood of success is calibrated, you use it. But if you cannot, if this pattern is out over the distribution, you're actually teaching the machine to say, I don't know. And this is really a crucial capacity when it's not like we're trying to understand why microwave works so it doesn't. The microwave or your car tells you, you should bring me to the mechanic. And that's what we developed a number of new machine learning algorithms. There was some machine learning publication about calibrated selective classification when machine learns when you cannot trust its likelihoods. And I think this direction of machine and not humans making the decisions when you cannot trust are really key to the future development. So just to summarize, I think that there are algorithmic solutions for safe and equitable AI deployment. Many of these techniques are currently in development. It's a new need that people didn't have in other fields. In clinical care, you really need to ensure that you are safe, that you work on different populations, and you know when it cannot be trusted. And they show you models for uncertainty, mention at least, uncertainty quantification calibration, anti-bias training, and distributional shape detection. And I just wanted my 6 minutes to show you as an ad, MIT MGB AI QS conference, where we are discussing with our clinical collaborators how to take this AI and safely deploy it in clinical care. Thank you very much.